Calls for the management of a Morgagnian cataract. This is being done under topical anesthesia after staining the anterior capsule and after inserting viscoelastic. Main port and side port is being made. "26 gauge needle was used to make a nick in the anterior capsule. The milky fluid is coming out, which is being taken out with the help of viscoelastics. You can see how much time taking it is. Now again we are trying to make a small circle in the center. It's quite tough because the anterior rhexis flap has got no support. Again you can see milky fluid is coming out, viscoelastic is being injected. Now at the end this circle is being completed. Repeated injection of viscoelastics has led to removal of lot of milky fluid and almost there is no support for the flap, which is making it tougher and tougher. Finally, a small circle has been made. Now we are just trying to take out the milky fluid very gently so as to have an idea what is lying beneath. Now a venous scissor is being used to make a cut in this circle, and with the help of rhexis forceps a bigger rhexis is being made. You can see after every 2-3 clock hours I am trying to hold the leading edge of the anterior capsular flap. We should not hesitate to put in injection of viscoelastic in between. Now a bigger complete CCC has been achieved. The downside of this whole procedure is that there is no support for nucleotomy procedure. You can see almost only the central hard nucleus part is left out, and doing any sort of nucleotomy and chopping is very tough. So the whole procedure is being done very gently and in a very controlled manner. The burst phaco mode has been put on. You can see the red glow from behind, and this was a supracapsular flip. It's safer because the nucleus has almost come out above the plane of anterior capsule, and so any sort of maneuver is actually not putting any stress either on the posterior capsule or the zonules. It's a well-known fact that zonules are very weak in these cases. So each and every step is being done very gently. Chopping the larger fragments into smaller fragments will lead to lesser consumption of phaco energy. That is the principle behind this procedure. I don't hesitate to change the chopper with the blunt instruments at the end of surgery so as not to damage any structure, because there is no support behind. Now for taking out very small but harder fragments, no need to put phaco probe again and again. This can be taken out by slow sustained injection of viscoelastic and by pressing the posterior lip of the main wound. While putting IOL, we have to keep in mind that zonules in this case are weak, so inserting the IOL has to be a very slow movement. Using the second instrument in the other hand actually blocks the flipping of IOL, which I encountered many of my cases. The haptic has been put into the bag with the help of viscoelastic and the second instrument.
Thank you very much, Dr. Shalini. I think it was really very well managed. We all know that Morgagnian, see, I use this technique of two-stage axis in intumescent cataract, sequential two-stage. I have been teaching for years this technique. Make a very small axis in center, and you are making with cystitome. I think these zonules are also weak. If you use forceps, it's faster and easier also.
The first one I made with the 26 gauge needle. The bigger one I did with the Rexus forceps.
No, I'm saying initial also.
Achha.
If you
I'm not used
you
to
make
it, sir.
yeah. Another thing is, if you use viscoelastic cannula from side port, keep it there, and when little fluid is coming out, you keep on putting viscoelastic, and with forceps you can. It becomes faster. You can do that by manual, no?
My left hand is not so good.
Yeah, so that's what I'm telling you. You just keep on injecting visco, it will push off whatever, because pressure as such is not much in these cases.
Yes.
Problem is that zonules are weak and you have anti-capsular plaque, no? So many times that causes problem. And second thing is, of course, zonules are weak, so you need to be careful. If you have severe zonular weakness, I tend to put CTR before I start phacoemulsification. So that also helps in Morgagnian cataract. And chopping, of course, it was not that hard cataract, yes, but many times we have very hard nucleus that keeps on rotating.
Keeps on dancing, so it's become very tough. And I'm used to modified stop and chop, not the direct chop. So it's tough for me.
No, the technique which you showed works best, I think, in these cases. I also use same, but only thing is I make a drill in center so that you go deeper. You hold it deeper and then chop so that, there's no rotation.
Yeah, but it was rotating quick so many times that I couldn't think of anything else.
Yeah. Arup sir?
Yeah. So quite well done. What I have noticed over a period of few decades, that you don't get an Argentinian crack sign in these kind of situations.
Yes, sir.
It looks very dramatic, there's an explosion, there's a plume of fluid cortex, but it doesn't extend to the periphery, number one. Second thing is, as Harshul had mentioned, cystitome is okay to initiate the flap, but once you have got a flap and you want to complete the primary rexis, cystitome is not very effective or efficient because you don't get any purchase on the capsule. Yes. So you need to use the microrexis forceps for that. And third thing is the scissors that you have used, Vanna scissors, So I mean, normally when we when you close the scissors, we ensure that the tip doesn't close. The tip is, you don't cut it fully. You just make the small incision, small nick, and then that is enough. Like if you cut it fully, try to cut it fully, then periphery, the tip, you may, like what I saw here, they are not getting aligned properly. There's a little crossover, and sometimes it may work as a forceps. So you just make the nick, that's it. Make sure that the tip doesn't approximate. The tips of the scissors, they don't approximate. And capsular plaques is quite well known in these patients, fibrotic capsular plaques. And zonules are weak. So I would use a viscoat in this patient to put all around the fornix, capsular fornix. So make sure the viscoat stays, it doesn't come out. And it also stabilizes the zonules. Otherwise, the whole thing is a little floppy, and sometimes when the AC shallows down abruptly, the zonules also may stretch and they may tear. So keeping a little bit of viscoat on the periphery all around, it makes a lot of sense. And as regards phaco, of course, you have done a good phaco, and it is not a tough case, but as Harshur had mentioned, you can make a central sort of a well.
Yeah.
Now, how do you make the well? Because well is not a fixed part of the nucleus. You can stabilize with your left hand instrument, Sinski hook, and then just drill a small well at the center or maybe a little superiorly, and then chopping becomes very easy. But what you have shown is also pretty nice, and particularly the last bit of nucleus, trying to remove it may result in a PC dent.
Yes.
That is also, that was a very good demonstration that you conveyed. And this patient somehow, the posterior capsule also quite stretched out. So, I have noticed, we are doing nothing, waiting for some next step, and then the posterior capsule has just opened up, So, posterior capsule dehiscence, thinning and weakness is also well known. So, you need to be prepared.
Yes.
So, all these things are told to the patient beforehand, that these are things that may happen.
Thank you very much, Dr. Shalini.